So that's our notification that's being recorded. So thank you very much, and take it away, Donn.
Thank you very much, and thanks for having me. I am always thrilled to be able to talk about my area of interest, which is insomnia. And today, something that I don't get to talk very much about, which is acute insomnia, because we so rarely in the field of behavioral medicine get to see it or look at it, because we are always seeing people who are much further down the road. And that's pretty much the story that we want to talk about today. And that is, there we go. There's this perfect storm, ultimately, that we are now facing with everything that's going on with regard to coronavirus, and more specifically with regard to the actions that we're taking in order to protect ourselves with regard to social distancing, with regard to being home from work. Our children are home from school. And that is also altering our normal routines and our schedules, which not only can potentially precipitate problems with sleep, but also be the kinds of things that can lead people down a path that can make them have a much more chronic problem with sleep that will be much more difficult to deal with down the road. So the question is, can we and how can we prevent the epidemic of what I'm going to call chronic insomnia after this pandemic? So let's define terms a little bit first. Now in the latest iteration of the DSM-5, we have this classification of insomnia disorder. And this is essentially a difficulty initiating sleep, maintaining sleep, or waking too early. When we say difficulty, there really are no severity criteria for how long is too long. There was one paper that looked at that, but the general rule of thumb that we've used in behavioral sleep medicine has always been 30 minutes. So if it takes you more than 30 minutes to fall asleep, if you're awake for some combination of more than 30 minutes in the middle of the night, or if you wake earlier than you want to by more than 30 minutes, that's what we mean by difficulty. And insomnia is not something that you have every single night. Almost nobody does. So we have this criteria that says one or more of these sleep continuity disturbances needs to be present for at least 3 nights per week. And then we have a duration setting now in the latest definition of at least 3 months. So you have to have this every week, you have to have it a lot, and you have to have it for a long time. And I can tell you from experience that once you get to that 3-month point in time, it usually is not something that's going away on its own without some sort of focused or targeted treatment. And the patients that I wind up seeing have had insomnia for years and years and years. Also, we have this notion of poor sleep occurs despite adequate opportunity. All we mean by that is there are going to be a number of people, maybe even a larger population, that we might say have sleep insufficiency. This is what the National Sleep Foundation is always yelling about, which is basically if people are burning the candle at both ends, if they are, because of their work schedules, because of child routines, because of a whole number of different things, not getting to be in bed enough and therefore are tired during the day, that's sleep insufficiency and not insomnia. Insomnia implies that you have the opportunity to get the kind of hours you need and are unable to do so. And then the last thing about insomnia disorders, we need to think about it as a 24-hour disorder, not just a nighttime thing. So it has to be associated with some form of daytime impairment or distress. And the bar is very low. It just has to be one of these things. So if you have problems sleeping at night and you feel tired the next day, you meet the criteria. And if you're doing that long enough, that's criteria for chronic insomnia. So fatigue or sleepiness, problems with attention or concentration, problems with job or school performance, mood disturbances, even just being irritable or crabby the next day would make the diagnostic criteria. Motivation and energy or an initiative reduction, proneness to errors and accidents, and physical symptoms like tension, headaches, or GI symptoms. So again, any one of these things would help to make that diagnosis. In terms of general population prevalence estimates, there are a number of studies going back looking at different things, but it is not uncommon to see generally a population prevalence rate of about a third, about 30 to 35% for acute insomnia. There really is no definition for acute insomnia in the DSM. It is sort of bundled up into the category of insomnia disorder not otherwise specified, and is mentioned as a brief insomnia disorder, but the only difference is the same criteria, except you haven't met the duration of 3 months. In terms of the full-blown insomnia disorder, then we were getting estimates anywhere between 6 and 15% for chronic insomnia or insomnia disorder. And that's in the general population. When we start to look at mental health populations, when we look in the VA and look at people who have problems with depression and post-traumatic stress disorder, those numbers can soar up to the 50 and 60 and sometimes 70% range. So very prevalent, almost epidemic-like currently. Now, acute insomnia, to kind of look at that, we don't define that as well, but this is a paper by one of my colleagues, Jason Ellis et al. And this was the first attempt of its kind to really maybe make a better attempt at defining acute insomnia and maybe looking at stages of this to sort of pave the way for asking the question, how do we get from one to the other? What is that transition like? And maybe how might we prevent it? And so one of the things they did to try to define this was define a trigger event for any acute insomnia, which makes sense. Any life event or train of life events which result in significant reduction in quality of life from individuals, from the individual's ideal, and distress at that situation. And I would say we are not going to get any argument. I'm probably not going to get any argument from any of you that the current situation we all find ourselves in would qualify as such a trigger. Again, they're going with that same minimum frequency of 3 or more nights per week of disturbances of sleep continuity. And then they start to chop this up into subcategories. So they're basically saying, look, if you have 1 or 2 days of insomnia, we're not even going to trifle with that because that's universal. If you ask people if they've ever had problems sleeping, every one of us has had that from time to time. So they start the clock essentially at 3 days to 3 months and chop that up from 3 days to 14 days and call that acute. From 2 weeks to a month, they're going to call transient. And then interestingly, that from 1 month to 3 months, they start to call this subchronic insomnia disorder. And it's interesting to me because in the older iterations of the DSM and the ICD, the definition for insomnia included a duration of only 1 month. And so now we're sort of saying, look, somewhere in that period of around 1 month and transitioning over to 3 months, you're already starting to develop the kinds of issues I want to talk about soon that are probably leading you down a path that it's going to make it difficult for this insomnia just to go away on its own. So the question with regard to chronicity is this: if chronic means that recovery and remission does not occur spontaneously, then when does this occur for insomnia? When in that 1 to 3 month time, or maybe earlier, does that occur? And then the question is, does that definition of acute and chronic bear on treatment? That is, would we think about looking at chronic versus acute insomnia differently and what we might do about each of those? This is an older study by O'Hayan looking at prevalence over time in terms of its duration. But I'm utilizing this to kind of frame the question to say, when we get to about that period of 1 month, and maybe even a little bit before, the question is how many of those folks are actually transitioning over to the more chronic form, and what does that path look like? So here's a much more recent study on the natural history of insomnia by a colleague of mine, Michael Perlis, who is at the University of Pennsylvania. And they've taken a large study basically looking at how people sleep varies over time. They've created a website for the National Initiative for the Tracking and Evaluation of Sleeplessness, aptly named NIGHTS. So what they did was to kind of invite people to come to this website. And for the initial study, what they did was to go to Zogby International and Research Match and ask the simple question, are you a good sleeper? That was the entrance qualification, and that they have a study for you. And so people who then came to that and answered the question for the advertisement that they were good sleepers, they were then screened on a REDCap site to make sure that in fact they seemed to meet the criteria, which for this study was basically saying you're a good sleeper if you, for 5 days or more out of the week, it takes you no more than 15 minutes to get to sleep, or you are not awake for any longer than 15 minutes in the middle of the night. So that's a pretty good bar for a good sleeper. If you met that at that point, you were then referred to the website. You then logged in and had to sign informed consent and went through an initial assessment battery, which was fairly intensive. It took essentially 1 to 2 hours to complete, and it entailed all kinds of questionnaires on sleep and sleep medicine, as well as mood, anxiety, mental health issues, medical health issues, and so forth. And you had to fill out 2 weeks of sleep diaries and fill out questionnaires at the end of each week to basically confirm that good sleeper status, to make sure that in fact what you had said in the initial screening was in fact true. And then you were sort of entered into what was called phase 2 of the study, which was then you were followed for a year, filled out sleep diaries every day, and then some weekly questionnaires and monthly questionnaires. And also in that phase 2, the first 12 weeks were considered sort of a baseline period also to confirm a good sleep. So the initial screening cohort was over 3,200 individuals. In that first 2-week period of time, 85 people were disenrolled because they did not meet the threshold for adherence to filling out the sleep diaries, and that was a 60% threshold. Then if you got through that, you entered into that phase 2 period of time. And you were followed over a year. And at the end of the year, they still excluded over 1,900 people for one of 2 reasons. Again, if you did not meet that 60% threshold for adherence to the diaries in any 2-week period of time for the year, and also if in the first 12 weeks of the study, in the first 12 weeks, that was really considered the baseline period. And if in that period of time, in any 2 weeks in that period of time that you met the criteria for acute insomnia, you were also excluded from the study. And so of that 1,900 people, I would say it was about half and half. About half were non-adherent and half, somewhere in that first 12 weeks, met the criteria for acute insomnia or maybe even chronic insomnia. So we wind up with a final sample of a little over 1,200 individuals, and what they did was to follow them and to say, okay, over the course of a year, how many remain good sleepers? And the answer was 73%. But what they were really interested in is during the course of the year, if you had a bout of acute insomnia, which again was defined as a 2-week period of time of poor sleep, those numbers was 27%. And then they followed them over the course of the year to say, what happens to those people with acute insomnia? And what we're seeing is 72%, a little over 72%, after the acute insomnia recovered. So that's what AI-REC stands for. And so they recovered. And we can also see that 6.8% went on to develop a full-blown course. This is incidence, 6.8%, a full-blown course of chronic insomnia. And only 1.5%, once they had met the criteria for chronic insomnia within that period of time, recovered. We then also have this other category, PPS, which is persistently poor sleep. And a full 19% of individuals, after they had a first bout of acute insomnia here in that year, never quite recovered fully. So what this is are people who are having potentially weeks to months of poor sleep, but never meeting the full criteria of 3 months for chronic insomnia. So they might have a 2-week period of time within a 12-month period of time where they slept better, but never fully recovered. So again, what we can say is that there were, between the poor sleepers, the persistently poor sleepers and the chronic insomnia individuals, we can say, maybe we can make this statement that once you have a bout of acute insomnia, something like a little over 25% or more maybe transition to a group of individuals who are never quite getting off that train and are always having either a full-blown chronic insomnia or constantly repeating long bouts of acute insomnia. And once you get into that stage, is that kind of insomnia a problem? Well, it's a problem because there are many clinical correlates for chronic insomnia disorder. First of all, it's associated with increased medical morbidity, and we're having a wealth of information that now tells us that this is now associated with and can be risk factors for such things as hypertension, obesity, problems with losing weight once you are obese, problems with diabetes, cardiovascular disease. And there is now mounting evidence that lack of good sleep may be at least one of the risk factors in Alzheimer's disease and other forms of dementia. And then, of course, we also have it's associated with increased psychiatric morbidity. And this has always been sort of a one-way arrow. It's hard to find a diagnosis in the DSM-5 right now where you couldn't find insomnia as a symptom. And that's sort of how this is always taught in schools and in graduate programs and in medical school, that we tend not to talk about insomnia enough, as far as I'm concerned, because we always think of insomnia as a symptom of all other problems and just treat those problems and it will go away. But we're finding that the evidence does not support that, that once you have this chronic insomnia, unless you target it more directly, it tends to be very sticky and does not go away. And also, we have now a number of studies that have shown that you have, for a 2-week to 4-week period of insomnia, you then have a 2 to 4-fold increased risk for even a first episode of depression. So we can either say that insomnia is serving as a prodromal symptom and in many a risk factor for the onset of depression. And we also know, given that it doesn't go away all that easily, even when you treat things like anxiety and depression and pain, that when comorbid, at least with depression, and we know this with anxiety as well, that the insomnia that stays there is associated with poorer response to treatment to the depression. So far from just being able to treat depression and make it all go away, the insomnia will actually interfere with one's ability to recover from their depression and their anxiety and so forth. So having chronic insomnia is not good news. Is it the same with acute insomnia? Is insomnia as much of a risk factor? Well, I'd say the only risk factor is that of developing chronic insomnia, because acute insomnia is more of, I think, a call to arms, a normal thing. And we have this wonderful quote from one of the fathers of behavioral sleep medicine, Art Spielman, who basically said, no matter how important sleep may be, it was adaptively deferred when the mountain lion entered the cave. And we should all take this as fairly well true. We should remember that sleep we see sleep in every species on the planet, but it's a very costly behavior. You are at far risk when you are asleep. And so it must be, number one, performing a very essential function. And it is nonetheless costly. So under times of threat, it makes sense that it needs to be, as he puts it, adaptively deferred, that we need to be awake in times of fight or flight when the lion mounted enters the cave. So we can think of acute insomnia as a call to arms and as a normal part of the response of fight or flight and adaptation to change. But what's the model for this to then move from an acute normal situation into a more chronic abnormal situation? And so what I'm going to present again here is Art Spielman's model. We call it the Spielman model, or the 3-factor model, or the 3P model for the evolution of insomnia. And what we have is a threshold line for insomnia. Very simply stated, above this, you have insomnia. Below it, no insomnia. And premorbidly, before ever there was a problem, we'll say that there are a set of predisposing factors. Essentially, what this can be thought of as vulnerabilities to the possibility of developing insomnia down the line. Some people are going to be more prone to having bouts of insomnia and maybe chronic insomnia than others. Most of these should be considered genetic factors, whether it is genetic sleep factors that make you have what, for lack of a better term, might be a weak sleep generating system, a very odd preferred sleep phase in relation to normal society, even coming from a background where you come from a family of individuals where you're genetically predisposed to anxiety might make you someone who is more predisposed eventually to developing insomnia. But again, here at this point in time, there is no insomnia. It takes some precipitant or trigger, as Dr. Ellis and company suggested, to set off an acute insomnia. And again, we should definitely think of coronavirus, and more importantly, the distancing that we do, the social isolation, the changes in our structure of life and the timing of things that we do in life that can serve as great precipitants for acute insomnia. But what we hope for any precipitant of acute insomnia is that eventually there's a remission of that precipitant, that either we treat it we deal with it, it remits, or we adapt to it, it goes away, and in a perfect world, we would then no longer have insomnia and return back to normal. And as we saw, a full 73% or so of individuals do follow this path. But what we see for some is the development of what we might call perpetuating factors early on, somewhere in that period of time, between maybe several weeks and a few months of having acute insomnia that doesn't tend to go away, we see the development of these perpetuating factors. And again, I'm going to say that coronavirus is a stressor that is unfortunately going to be with us for a little while. So we may see a lot of this being precipitated and constantly being a stressor. And what we say in this model is that in the long term, it is these perpetuating factors that keep us locked above this threshold for weeks and months and years at a time. So what are these perpetuating factors? And to discuss that, I want to go a little bit into general sleep medicine and talk about something that we call the two-process model. This is Borbely's two-process model. And at the bottom, we have just a timeline. What you're seeing here is just sort of a day and then an 8-hour night for sleep, and then a day and again, another night. And we want to talk about these two processes. So one of the processes is process S. This is a homeostatic drive we refer to as sleep drive or sleep pressure. A good analogy for this, it is very much akin to another homeostatic drive, which is hunger. And as we all know, every moment we go from our last meal, we get more hungry. Eventually that hunger drive becomes insistent. We eat and the hunger goes away. Likewise, with sleep, once we wake up in the morning, sleep drive builds over the course of the day in a linear fashion. And what we want at the time of bed is a very strong and healthy sleep drive. And then what we see is that this then exponentially leaves as we are asleep at night. And then we simply repeat this pattern over and over again. If it were just sleep drive that regulated sleep, we would build enough sleep drive in the middle of each day to be very much in need of sleep. We would all need to roll up in a ball after about 4 hours. And likewise, in the middle of the night, after 4 hours of sleep, we would dissipate enough sleep drive that we would be waking. And so without other factors involved, we would all be waking for and sleeping for and waking for and so forth. Fortunately, we have a circadian rhythm, and we call that process C. And we all know that the circadian rhythm is something that regulates a number of different bodily functions, from hormone secretions to body temperature and a number of other things. Every cell in our body contains a clock, but the pacemaker for the clock, the super clock, is in the hypothalamus, in the suprachiasmatic nucleus. And we have a circadian rhythm with regard to sleep-wake cycle. And so for the purposes of this talk, this process C is really very much about wakefulness, or for lack of a better term, alerting signals from the brain in opposition to that sleep drive. So it is that wakefulness, or that drive for wakefulness, or alerting signals from the brain, that keep us awake, and mostly keep us awake in the second half of the day. And it's the utter absence of those circadian signals in the night that keep us asleep in the second half of the night. Now you'll notice for good sleep here, we don't want the height of circadian rhythm to be here at bedtime. We already want a downward slope of wakefulness. So it is both the combination of strong sleep drive along with a decreased wakefulness that is on that downward slope that should produce good sleep. And we see this happening over and over again. Now, Borbely only talked about those two factors, but we also should be aware that there is probably a third process here that we might call process W, for wake or arousal. And here what we mean, I've already made a statement about this, is that the arousal system can override the sleep promoting system in order to allow us to respond to danger. This is that notion that sleep is going to be adaptively deferred when the mountain lion enters the cave. But again, any sort of adaptation or change in life or stressor can cause this arousal system to kick in and override. But again, as we start to think about longer term problems with sleeplessness, one of the things that we start to note in people who have these problems is that there's a shift in focus, not just from onto the stressor at hand, which for us right now might be work life and financial life and health, but also onto the sleep itself. As one starts to become more worried about sleeplessness, about the effect it's going to have on their productivity during the day, on their health long-term, that can serve to promote an overactive arousal system that will continue to interfere with the two processes regulating sleep, which is sleep drive and circadian rhythm. So again, coming back to what good sleep looks like, we should have this mix of a strong sleep drive plus correct circadian placement plus low arousal, and all of that at bedtime should equal good sleep. But the problem is, as you start to transition from acute to chronic, the question I ask is, how might individuals with acute insomnia begin to alter their behaviors in ways that will affect sleep drive and circadian timing? And again, it's this shift of, not only am I having a problem with whatever the particular stressor is, but I'm also having a problem with my sleep, and now my attention is diverted to that. And now I try to take a hold of that by doing certain things that actually will wind up backfiring and disrupt both circadian rhythm and sleep drive. So what kinds of factors might weaken sleep drive? First and foremost of these things is excess time in bed. Essentially, people, when they have trouble sleeping for a long period of time, begin to think that what they need to do is compensate for the lost sleep. If I've lost a lot of sleep in a couple of days, maybe what I need to do is try to make up for some of that sleep and sleep longer. And if, by the way, I can't count on that sleep, maybe I need to spend more time in bed waiting and hoping for when the god Hypnos visits me, I will be there and be ready when it comes. So people wind up going to bed earlier. They might inadvertently fall asleep on the sofa, thus extending their sleep opportunity window. They sleep in later in the morning when they've had a poor night. They might also nap. And again, especially long naps are not a good thing. Remember, let's go back to that analogy of hunger. If we think about hunger as being a homeostatic process and sleep drive being a homeostatic process, napping would be akin to snacking. And your mother always told you that snacking, especially close to dinner, is going to ruin your appetite. And so even dozing, which we might consider micro naps or small naps close to bedtime, are going to have a profound effect on that sleep drive in ways that earlier naps and shorter naps are not going to have the same kind of effect. Sleeping in on weekends, crashing to make up for if I had poor sleep during the week. Maybe if I can get 8, 9, 10 hours on the weekend, I can make up for that. But unfortunately, what that does is to put us all in deficit for sleep drive as we begin to start our week again. So again, these are all factors that can disrupt sleep regulation and sleep drive over time, so that we continually have a problem over and over with sleep. From the point of view of circadian signal strength, what maintains that? First and foremost, timing and amount of light exposure. It is light exposure that sets the clock, essentially, and keeps that clock entrained. If we had no input for the circadian clock, the truth is, if we had no sense of time and day and night, our sleep-wake cycle would tend to drift around the clock slowly each day. Now, timing and amount of light exposure is best maintained behaviorally by waking up and getting out of bed at a regular time each day. So again, I ask you all to think about the fact that already people may be giving themselves allowances not to have a regular wake time, that they might be allowing themselves to sleep at different times of the day, to nap more since they're home, and to get up at different times of the morning because they no longer have that alarm clock getting them ready to get up, get to work, and get into that commute. So this is one of the risk factors that I see in this particular stressor that we all have now. Other regularity does go into helping to maintain a good clock. So while light is the single best time cue for the pacemaker, regularity of activities such as eating and meal times and exercise times also will help to regulate the clock. And we might imagine for some that all of these are being disrupted as well. Anything else that people might be doing, problems that could be associated with causing an acute insomnia to turn into a chronic insomnia? And I would say dogs. And really, we're not talking about dogs. I love dogs. Dogs are fine. But what we're really talking about here is classical conditioning. So look, in a normal, good sleeping situation, what we all hope for in the best of all possible worlds is that your bedroom and bedtime is associated primarily with sleepiness and sleep. And that's a good situation. In the acute insomnia situation, it is often the case that people are still going to spend time in bed, but be awake. And what's going to wind up happening is they tend to hold onto that mattress for dear life, hoping that they can get to sleep. And they're taking that life stress to bed with them and associating the bedroom and bedtime with life stress and induced somatic arousal and cortical arousal and worry. And so even later on, as we said, the precipitants eventually go away. But once this has been conditioned over a period of time, we now have a chronic insomnia situation in which the bedroom and bedtime is a conditioned stimulus, if you will, for somatic arousal, for cortical arousal, for worry, and so forth. So we call this conditioned insomnia, where the bed has been repeatedly exposed to, has been repeatedly associated with sleeplessness and tossing and turning and upset, and that's conditioned insomnia. So what are the implications for treatment that we should be thinking about here? I would say first and foremost that what we want to do is get on top of acute insomnia when we can. I would say I have, in my career as a behavioral sleep medicine specialist, not really had much opportunity to see people with acute insomnia. They don't tend to come. People do not tend to talk about their sleep problems when it's gone on for only a couple of weeks, when it's gone on for a month. They tend to look more at the stressors and assume what we all assume, which is when that stressor goes away, my insomnia will go away. So they don't go to their physicians. They don't go to their mental health counselors in the early stages of insomnia. And I think we have an opportunity now to be ready for this, to say, this is coming, that a lot of people are going to have more problems with sleep when they're under stress. And just the changes in our regularity and routine, as I've shown you, can now make it much more likely that people are going to have these kinds of problems. So is medication treatment indicated in the short run? It might be. In a sense, hypnotic medications were formulated for short-term use. But I don't know that we want to jump on everybody that has a couple of weeks of insomnia with medications. There is always a risk for then getting very dependent on those medications. What I'm much more interested in is this idea of preventing perpetuating factors, of essentially training, educating the population, either A, to not even get there by doing the right things, or how to take control quickly of an acute insomnia to see whether in fact we can prevent a chronic insomnia from happening. And I might argue that this should happen much earlier on. We all tend to respond to insomnia like it is pain, like something that we hope will resolve over time, that we hope will resolve with the resolution of other problems. But perhaps we'd be better to think, given what we know about sleep regulation and what people do as this starts to become chronic, of thinking of our sleep problems early on as infection. Strangely enough, we're talking about that here as well. Infection in the sense that if we don't jump on it quickly, if we don't educate our populace to think about poor sleep for several weeks as being a possible risk factor that they want to get on top of, lest it spread, I do think we want to start educating our population about that, of thinking about this much earlier in the treatment. Once we get to chronic insomnia, then yes, we're left to things like medical treatment, but medications there were never really formulated for long-term chronic insomnia. And really right now, the treatment of choice for chronic insomnia is cognitive behavioral therapy for insomnia. Even the American College of Physicians has now put out a guideline paper saying this should be the first-line treatment. And this is essentially the work that I do. And I see all these people with chronic insomnia. But for this lecture, we're not going to get into how do we treat with cognitive behavioral therapy. I don't have the time now to teach everybody to do this. What I want to do is talk about how do we prevent those perpetuating factors from happening to begin with. How do we make sure that we don't allow this to happen so that we can get people to go back to this and that there's no development of perpetuating factors over time. And I would say the perpetuating factors that we really have an opportunity early on to focus on are the behavioral ones. If we can get people to do the right behaviors, we can prevent disturbances in circadian rhythm, disturbances in sleep drive, and conditioned insomnia. If we don't allow them to be there in bed and to make up and compensate for sleep in the ways that alter these very important functions of sleep, then we may never get to chronic insomnia. And if that doesn't happen, then I would say we don't even get to the point where people are starting to develop even more tricky problems like sleep-related worry and sleep effort. And just for a moment, I would say sleep effort is something we often see in people with chronic insomnia. Let's remember that good sleepers put no effort into sleep whatsoever. If you see what we're talking about here, sleep should really be a very autopilot kind of process, not unlike heart rate and digestion and respiration. So basically what we're saying is that we see people with chronic insomnia engaging in sleep effort like they're working at sleep. They're trying to close their eyes longer. They're trying to empty their minds and relax their bodies. And we never see good sleepers do that. And the minute you start putting effort and energy into sleeping, that also serves as a very insidious perpetuating factor. But again, I would say that once we take more control of these behavioral factors, then we're not going to see this other kind of cognitive factor get into play. So if we are exposed to individuals who we know are under stress, what kinds of education can we give them even before they develop an acute insomnia to prevent them from doing that? Let's have everybody maintaining good circadian health. What does that mean? Wake up and get up at the same time most days. And I say most days, good sleepers will alter their schedule a little bit on the weekends. That is true. But all of us, almost all of us, are getting up 5 days a week, same time, to go to work, to battle with the traffic, to get in, and so forth. And now that may be altered. So we want to caution people not to alter their days, to still keep a rhythm. Even if it's a different time of wake up in the morning than they might have had when they were going to work, that's fine. As long as at least 5 days a week, they're getting up at that same time every day. We want them, therefore, to be at that time, first thing in the morning, getting good light exposure in the morning, sit by a good big open window or take a walk. We want them to have regular meals each day and at about the same time each day. And we want them to continue to get exercise. That's good for stress management. It's good for building good, healthy sleep drive. And also doing this with certain regularity is a good thing. We are diurnal animals. We want to keep the day and the night separate. Day is for activity and should be full of light. And the nighttime should be marked by some decrease in that activity and decreased light exposure and quieter activities. We always talk about keeping electronic device use to a minimum in the last 2 hours before bedtime. This is largely to not get a lot of light exposure at night. But again, the spectrum of light that alters the circadian rhythm the most is blue light. And so most of our devices now have blue light filters. And I would advise that most people download those blue light filters at a certain point in the night. Again, at least 2 hours before their bedtime, so that if they are looking at screens, that they're not getting a lot of blue light, and therefore that's almost as much as saying to the pacemaker that they're not getting a lot of light and that they are in the evening. We also want to throw in this idea that the bedroom should be very dark. Our bedroom should be as close to a place where you could develop film as possible, and it should be very cool. If we do start to see people who are developing a problem with a couple of weeks of insomnia, let's start to jump on this. We now have a great opportunity where we might be seeing these people where we didn't see them before. And the first thing we want to tell them is not to compensate for a bad night's sleep. Don't panic. Acute insomnia is normal. It's a call to arms. Use it. Don't compensate for a bad night's sleep, meaning get up at the same time each day, even if you've had a bad night. When you lose hours at night and then you sleep in the morning, you're both sending a bad circadian message and weakening sleep drive. Do not sleep in the morning. Do not retire to bed early or allow yourself to fall asleep early. And do not nap during the day. And again, going back to this idea of napping as snacking, let's remember that those naps are like snacks. And so if you must nap, nap for a short period of time, maybe 10 to 20 minutes. That's our so-called power nap. And the earlier in the day you do that, the less likely it is to have major impact on your sleep drive. And carry out all the same activities as if you had slept well. One of the big mistakes people start to make is they alter their days. They decrease exercise. They don't take on the harder tasks because there's a fear that if I'm tired and fatigued, I won't do as well. But of course, this also does not allow us to then judge that fear, to see how true that really is. And then people develop all kinds of catastrophic predictions about what they can and cannot do in the chronic version. Do not spend excessive amounts of time awake in bed. This is about making sure that we don't have that conditioned insomnia taking place. Best to leave the bed for only sleep and sex. Do not dwell on sleep, and certainly don't try or work at sleeping. Once you get there, it's probably a good sign that what you should be doing is getting out of bed. Also, do not worry, think, plan, or worry certainly about sleep in bed. None of that is going to do you any good. And so you should get up fairly quickly from the bed, get up and go into another room, and just engage yourself in something that's enjoyable and relaxing. Do some reading, do some TV, puzzles, games, etc. I would not engage in work activities at a time to make up for what you lost during the day, because then you're just training yourself to wake up to get that work done. In terms of substances, yes, we don't want you to overdo substances. Look, caffeine may help people to feel more awake during the day, but do it in moderation. And avoid caffeine within about 6 hours of bedtime. That would be in an average person for half-life. Reduce alcohol. Look, alcohol can make you more drowsy and sleepy in the first part of the evening. And if we are trying to get people to stay up until a set bedtime, we don't want them falling asleep inadvertently before that and getting more drowsy. But we also know that alcohol wears off quickly, and then when it wears off, it fragments sleep in the middle of the night, and therefore produces more middle of the night maintenance insomnia. And so alcohol has never been a good sleep aid, and certainly people should not be using it as a self-medication. Nicotine is also a stimulant, so we want to have people avoid nicotine within 2 hours of bedtime if we can. And also definitely try not to smoke if they are awake at night. This is going to be easier for people who are not quite as addicted. And this is probably not a good time to have people engaging in smoking cessation. Things are hard enough. If you can't sleep, by all means, do not try to force it. You cannot make it happen. And the more you try, the more it's going to backfire on you. Let's remind everybody that acute insomnia is a call to arms and a normal response to stress. And the best thing to do is to leave it be. When left to its own course, your insomnia will right the ship. Your sleep regulation will right the ship in 2 to 3 days. And it stands to reason that this is true. Look, if you don't compensate for poor sleep, if you don't sleep into the morning, if you don't go to bed earlier or nap during the day, and you've just lost more sleep over a couple of days, you are just building more sleep drive that eventually, like a good sleeping pill, will put you to sleep in 2 or 3 days. And so that's what should happen if you don't put your hands on it and try to do anything. But if things haven't improved over 1 to 2 weeks, and people are starting to show evidence of a real chronic insomnia and real anxiety about this, then I would suggest that they might want to seek out professional help from a sleep specialist. How can any of us help with patients if you're seeing patients? Please certainly ask about sleep. We don't do this enough. Our patients don't come to us talking about their sleep. They talk about their other problems, and sleep is a secondary issue. And we don't ask enough. Let's ask about it. And let's use this as an opportunity to prevent perpetuating factors in those with acute insomnia. We might think about using possible medication, again, in those who are maybe the most stressed and anxious and really need something to kind of help them in the first week or so to sleep well, with an ending point so we know we can end that medication, but maybe that will help them not to have poor nights of sleep. So again, what we are doing is preventing perpetuating factors. So maybe medication for a short period of time while we do that perpetuating factor education. And if they are continuing to have problems, refer them to a specialist for chronic insomnia. Where can you go for that? You can find a sleep center at the American Academy of Sleep Medicine website, and there is that. And if you're looking for somebody who can specialize in behavioral sleep medicine and CBTI, that would be a behavioral sleep medicine specialist. And there is a Society of Behavioral Sleep Medicine, and there is their website. So now I'm going to stop, and I'm going to allow there to be time for questions. And I thank you all very much for your time. Thank you very much.
Donn, thank you so much. That was incredibly helpful. I think from the day we started doing this webinar, a lot of people have been asking questions about sleep. So I thought your helpful recommendations were quite useful for many people. So folks who have questions, you could post your questions in the Q&A box. I have some questions coming up. One is, this is a constant theme that I've heard also from other people. There has been reports of increased intense dreams or crazy dreams.
Mm-hmm.
Is there any research to support this in the situation of acute insomnia or stress-induced insomnia? Is that a normal reaction that you would expect in times like this?
Well, that's a great question. If I haven't conveyed it already, there's so little research on acute insomnia. That's one of the reasons why I say that we have this great opportunity, because we may be seeing more people coming in talking, especially in the mental health field and maybe in primary care offices, talking about their extra stress. If we ask about sleep, we might find some of these things. And again, I would always love to do this study where we can say, can we prevent this if we see what we would do by getting on top of those perpetuating factors? But in answer to the dream question, dreaming is always sort of a response to emotional stress, a way of working through issues and problems. And so it does not surprise me at all. I would consider it very normal for people to be having what we might call COVID-19 dreams, or any other kinds of dreams that have to do with danger and disaster. It wouldn't surprise me at all that that's happening in the acute phase of insomnia. Maybe more so than even the chronic phase of insomnia, where the dreaming is likely to, I think, settle down and not be the major issue.
I know that we have over 170 participants, so I'll try to choose and pick the questions. One question, which is I think also true for many first responders, is do you have any recommendation, people who are working night shifts or who may have a different circadian rhythm, compared to other population? Do you have any suggestions, particularly with artificial lights, that suggestions that you've provided?
Well, yeah, I mean, in general, third shift work and shift work is a very difficult kind of problem. It's different than insomnia, really. It's a circadian rhythm disorder. We were mostly made to work during the day and sleep at night. And so when we try to shift people to other time frames, we're not really prepared for that. It is true that people can shift their preferred phase to a different time of the day by manipulating light and trying to, expose themselves to the right amount of light in the evening, and then keeping things very dark during the day. But the truth is that unless they're keeping a regular schedule and trying to live on that shift, it becomes much more difficult. So our tendency is always to say, I work on third shift, but I want to live on first shift. And when people do that, they're constantly moving back and forth between two different frames of time and phases. And that makes it much more difficult for them to adjust. What I would say to people right now is we're not going to change your jobs and the time frames that you're working in. Certainly, I would still say people getting home in the morning, if they're allowing themselves to sleep, they should be allowing themselves a little bit of wind down time before they actually just try to plop themselves into bed. And then they should try to cordon off, make as dark a bedroom as they possibly can. Sleep masks are good. And so wearing a sleep mask and darkening out all light in that way, I think, is a good thing to do. Still setting yourself a specific wake time to get up and then get your day going. And trying to get more light exposure in the evening if you can, maybe with artificial or blue light sources when you're working. And then also potentially for those especially working on third shift, maybe they won't be able to get a full 7 or 8 hours when they go to bed in the morning, but a small nap then before work time is something that we often suggest to shift workers.
Thank you. Thanks, Don. Let me try to combine two questions. One is, do you have any recommendations for children who are staying up late, given changes in school routines and activities? Another related point to that is, are there ways people can assist families who have children who have sometimes at night having nightmares or difficulty sleeping, particularly in earlier ages, preschoolers?
Yeah, so again, from a sleep point of view, the same rules apply to children as they do to adults. Children will have lots of reasons why they don't sleep at night, but at this point in time, we would again see it as a normal response for them to be having some problems with sleep as a result of the stress that's going on around them and the changes. And we'd also see it as a normal response to see it as a change in their activities and routines. So I would make the same recommendations for children to begin with as I would for adults, that there still should be a routine bedtime and a routine wake time. Again, I'm not saying that they have to get up at the same time they got up for school. If, a lot of, especially as we get into, I know we talked about small children here, but as we get into our teenage population, they tend to have a much delayed sleep phase, and so they tend to get up later. And if right now they want to get up every day at 8 or 9 o'clock instead of 6 o'clock, that's okay if they're not going right back to school in the next week, so long as they're getting up at the same time every day and not sometimes sleeping until 12 or 1 in the afternoon. And the same thing for the little children, although that phase is going to be earlier. I'd have them on a regular schedule. We should expect that they're going to have more nightmares. And like any other stress for children, we want to encourage them to be able to talk about what their nightmares are, about what their worries are to parents, so that their parents can help them through those fears. For parents to be sharing with them how they are also struggling with these same stresses and to try to put their mind at ease. And to remember that these are normal responses to the acute situation.
Thanks, Donn. That's very helpful. Do you have any advice or recommendations for people with underlying mental illness like bipolar disorders?
Yeah, that's it's an interesting one. I mean, again, there is this tendency, let's hold bipolar aside for just a moment. There is this tendency to think if you have a mental health disorder, that the insomnia is secondary to that, and that there's very little way of getting on top of the insomnia if you have this mental health disorder, so you have to control that first. But all of our data indicate nothing of the sort, that very much so, as I said, especially for something like unipolar depression, insomnia does not go away when we treat depression as readily as all the other symptoms, and that it often can interfere with and compromise the treatment of depression. So we've seen a number of studies where even just starting with sleep work like CBTI can have a profound impact on helping people to get better with regard to depression and help them to do better with their therapy for depression. Bipolar disorder is tricky because as you start to restrict people's sleep in their time in bed, it can make them a little bit more prone to mania. But what I would say is that if somebody already has bipolar disorder and is already sleeping poorly, they're already at risk for more manic episodes. And so, again, keeping a structure for people with mania, they do tend to sleep long when they're depressed and late. And what we want to do is keep them at the same number of hours every day and getting up at the same time every day. I know I sound like a broken record, but I cannot tell you how important that one item is for all of our patients. Whether they have a mental illness or not, they're going to do much better with regard to their sleep if they're getting up at the same time every day and not sleeping 10, 13, 14 hours, but only 8 or 9 or whatever it is that they need. That may vary from person to person, but getting the same amount of sleep each day is going to help to regulate structure, help to regulate mood, and help to keep them on a much more stable mood path.
Thank you, Donn. Maybe one last question. I'm mindful of the time. This is a contentious question that I have seen particularly in the sleep community and in parents. And as a parent of a teenager, I can understand this question, which is some adolescents may now have the opportunity to sleep late. Mm-hmm. They don't have to wake up early in the morning, catch the bus, and attend mortar and brick schools. As long as they are getting enough hours sleep, is this suggestion, is this beneficial? I guess, is it okay to sleep late now that they have an opportunity? They're not forced to wake up early in the morning.
Right. So I made mention of this when we were talking about the smaller children, and then I started talking about teens. So yes, our teens are more delayed, almost by nature, genetically. Almost the majority of our teens tend to have a delay in their preferred phase. So we know that they're much more night owls. We know we do a great disservice to them by making them get up earlier than the little children and going to school. And they are at much disadvantage there, and therefore often are restricted in sleep, right? Because they wind up staying up late because of activities, but also because of their nature is not to be able to get to sleep earlier. and then they have to wake up very early in the morning and are getting shorted on sleep. Now here we have an opportunity where they can sleep longer, and they're going to want to sleep later. And again, what I would say, as I would come back to, is probably okay, so long as they're not returning very next week to school, to let them sleep in a much preferred phase. If they want to go to bed later and get up a little later, that's fine. But I would still discourage them from letting that go too wild. If they have to get up for school at 6 o'clock or 7 o'clock, letting them sleep till noon is probably a mistake. But letting them sleep maybe until 8 or 9 will mean that when they have to make the transition back to school, they probably won't have as difficult a time making that transition. And I, by all means, would try to determine if they need, teens need more sleep. They may need as much as 8.5 or 9 hours of sleep. And so letting them get that kind of sleep is probably fine, but you want them getting up at the same time every day. I probably wouldn't be letting them sleep until 11 or noon or 1. And I would be making sure that they're not getting much more than that 8 or 9 hours on a daily basis. Otherwise, they're going to set themselves up for other insomnia problems.
Thank you. Thanks so much, Donn. Karestan, do you have any final words?
No, that was terrific, Donn. Thank you so much. It was really helpful, and I'm sure the audience found it helpful. And people have been asking, so we make the, like I said in the beginning, we'll make the recording and materials available to everyone. And we look forward to seeing you next week. Bizu, do you want to say a comment about what next week's forum is about?
Yeah, absolutely. So over the past few weeks, people have been saying how the pandemic is really slow in sub-Saharan Africa. And Karestan and we have strong research collaborations, and colleagues in Africa have been telling us some of the work that they are doing. So we're hoping to use that forum to discuss what they are doing in preparation for the surge in numbers and increased strain in the healthcare system in the continent. So we'll have a panel discussion next week. So watch out. I will send out an email and announcements through the listserv. If you haven't subscribed, if you want any materials, anyone who hasn't subscribed to the listserv, please do so. Shelley has sent out the link, so please make sure to put your name and email.
All right, great. Thank you, everyone. Thank you so much, Donn. That was fantastic.
Thank you very much for having me.
It was really informative. Thank you. Excellent. Thank you. Bye. Be safe and well, everyone. Thank you.
Take care.